Hello everyone. So the last time we left our lecture, we had talked about the neuromuscular junction. We talked about the postsynaptic effects of acetylcholine and also the receptors that were involved in the presynaptic modulation of acetylcholine release. Now we will continue our discussion with the most important depolarizing muscle relaxant. And that is called succinylcholine. There is one other depolarizing agent that causes depolarization, and that is called decamethonium. But for our purposes of discussion, the agent that is used most commonly clinically is succinylcholine. As I already mentioned in the previous lecture as well, succinylcholine is essentially very, very similar in structure to acetylcholine. In fact, as you can see from here, succinylcholine is nothing but it is two molecules of acetylcholine which are joined together by an acetate methyl linkage. And it is known by different names. So it is also known as succinylcholine, it is also known as scoline, and commonly we also sometimes just call it sucsa. So as I already mentioned, it is a depolarizing type of muscle relaxant. So neuromuscular blocking drugs can broadly be divided into depolarizing type and non-depolarizing type. I covered this in the previous lecture a little bit. So depolarizing neuromuscular blocking drugs act as agonists at the nicotinic acetylcholine receptors, whereas non-depolarizers act as competitive antagonists at the very same receptors. So succinylcholine is a depolarizing type of muscle relaxant. What is the mechanism of action? In order to understand clearly how succinylcholine produces paralysis, because see, it seems counterintuitive. On one hand, we are saying that succinylcholine is a depolarizing type of muscle relaxant and it is an agonist at these receptors. Therefore, it should have the same action as the physiological ligand, that is acetylcholine. Now we know that acetylcholine mediates muscle contraction, so succinylcholine should also mediate muscle contraction, but we know that succinylcholine is a muscle relaxant, it produces paralysis. So what happens is, when you give succinylcholine to the patient, I will just from now on, I'll just call it Sucsa for simplicity's sake. When you give Sucsa to the patient, there is an initial period of contraction. This is then followed by a persistent period or a prolonged period of relaxation, which we call as paralysis. So just like acetylcholine, it does produce contraction, but then followed by this contraction period, it produces relaxation. Now, if you remember from the previous lecture, I talked about sodium channels, right? So we had sodium channels. Now, sodium channels are essentially pathways within the phospholipid bilayer which allow sodium to cross from one side to the other. Most commonly, sodium travels from the extracellular space into the intracellular space along its concentration gradient. So it can be of two types. We have ligand-gated sodium channels, and we also have voltage-gated sodium channels. So ligand-gated channels, we know that they contain a transmembrane protein which makes up the pore, and then there is a binding site on the extracellular surface side where a specific ligand comes and binds to the site, and then this opens the pore and allows for the entry of sodium inside the cell. A very good example are the nicotinic acetylcholine receptors, which are ligand-gated ion channels. Now, voltage-gated ion channels, on the other hand, the trigger for opening the voltage-gated channels is a change in the voltage. Change in the voltage or the resting membrane potential. This is also known as depolarization. So the trigger for opening of ligand-gated channels is the binding of the ligand, whereas the trigger for opening the voltage-gated channels is the change in the voltage or depolarization. Now, most often, the voltage-gated sodium channels are also transmembrane proteins only, but they work a little bit different than the ligand-gated channels. So voltage-gated sodium channels can actually be present in one of the three states. Now, there are two types of gates that are present. So this is the phospholipid bilayer, and this is the voltage-gated sodium channel. Now, each voltage-gated sodium channel is going to have two states, or two gates rather. So the upper one is known as the activation gate. So this upper one is known as the activation gate, and the lower one is called as the inactivation gate. So as is clear from this orientation, will the sodium be allowed to go inside the cell? No, it won't, because the activation gate is closed. Therefore, sodium will not be able to pass through the receptor. But what happens, and this state is known as the resting state of the voltage gated sodium channel. But what happens when there is an incoming wave of depolarization? So when the depolarization wave comes, what happens to the activation gate? The activation gate opens up. But what happens to the inactivation gate? It will also remain open. And this will allow the sodium to enter the cell. So the activation gate is actually voltage dependent, whereas the inactivation gate is time dependent. So the opening of the activation gate will be caused by a voltage change in the voltage, but the opening of the inactivation gate will be caused by the passage of time. So as soon as the depolarization wave comes, that will not open the inactivation gate. It will merely open the activation gate. But the point from time from which the depolarization has happened, with the passage of some amount of time, the inactivation gate will then open. So the opening of inactivation gate will be dependent on the passage of time since depolarization, whereas the moment depolarization wave arrives, the voltage gated activation dependent activation gate will open. Now this is known as the open state. Then what happens is, due to the time dependent inactivation gate, the inactivation gate is going to close. But at this point, the activation gate is still open. So this is known as the inactive state. And this again will not allow sodium to move inside the cell. So there is just a very, very short amount of time window during which sodium can actually enter the cell. And in case of acetylcholine mediated muscle contraction, this opening is just for a few milliseconds, even actually less than 1 millisecond. Right? So, but how does it relate to acetylcholine or succinylcholine? Acetylcholine molecule is not going to interact with the voltage gated channels. They are going to interact with the ligand gated nicotinic channels. So how does voltage gated channels incorporate into all of this? So what happens is, as is clear from this diagram, here is your nerve, and this is your muscle, and this entire thing is the neuromuscular junction. Now the neuromuscular junction, or rather the muscle membrane, can be divided into 3 zones. So this zone, which is directly in contact with the neuronal nerve endings, is known as the end plate, whereas the zone that is just adjacent to the end plate is known as the perijunctional zone. The end plate is going to be rich in the mature nicotinic acetylcholine receptors. This we already know. But the perijunctional zone is going to have a lot of voltage gated sodium channels. In fact, not just the perijunctional zone, but even the rest of the muscle membrane is going to have a lot of voltage gated sodium channels. But the perijunctional zone is very, very important, because this is the zone of the muscle membrane that contains the voltage gated sodium channels that is in direct communication with the end plate. So whenever acetylcholine molecules are released at the synaptic cleft, they interact with these nicotinic acetylcholine receptors and cause a depolarization to occur at the end plate. This depolarization is going to trigger the voltage gated sodium channels that are present in the perijunctional zone to open up, thus causing in more sodium to enter. And in this way, the depolarization wave is going to progress from the perijunctional zone to the muscle membrane which is beyond the perijunctional zone. And in this way, the entirety of the muscle is going to get depolarized. Correct? But what happens in case of succinylcholine? So acetylcholine, as we know, is metabolized by acetylcholinesterase enzyme, and there is a lot of acetylcholinesterase enzyme present at the synaptic cleft. A lot of it is present. So the acetylcholine, as soon as it is released, it binds to the receptor, it detaches itself from the receptor and gets metabolized. So the half-life of acetylcholine is very, very small. But this is not the case with succa or scoline. With scoline, scoline is metabolized by pseudocholinesterase enzyme. And pseudocholinesterase enzyme is not present in the synaptic cleft. It is only present in the plasma. So it is present in the plasma and not in the synaptic cleft. Therefore, what happens is when you give scoline, whenever the scoline molecule attaches itself to the nicotinic receptor, then it is going to get detached, but it won't get metabolized, and then it will attach itself to the adjacent nicotinic receptors. And in this way, even one molecule of scoline will remain in the synaptic cleft for a very long period of time, in contrast to acetylcholine. So that is the fundamental basis of difference between the action of acetylcholine as a agonistic ligand and scoline as an agonistic ligand. Acetylcholine will only cause the channel to get opened for a very short amount of time, and then it will get metabolized. But even a single molecule of scoline will cause repeated openings of a lot of different nicotinic channels. Now what happens is, because of this persistent action of succinylcholine at the end plate, there will be a persistent depolarization at this end plate region. And this persistent end plate depolarization is going to lock the voltage gated channels which are present in this perijunctional zone. In which state? In the inactivated state. Because as we all know, whenever the perijunctional zone voltage gated channels will encounter the depolarization within the end plate, their activation gate will open and very quickly, and the inactivation gate will close very slowly. So there will come a point after the initial opening and passage of sodium, there will be contraction even with scoline, but after that initial contraction, the inactivation gate will close and the sodium voltage gated sodium channel will enter its inactivated state. And since this depolarization within the end plate is not disappearing because of persistent action of scoline, the voltage gated sodium channel in the perijunctional zone do not have the chance to get out of this inactivated state and go back to its resting state. And therefore, this perijunctional zone is going to act as a buffer. So all of the persistent depolarization at the end plate will be locked in the perijunctional zone and will not be allowed to travel to the adjacent normal muscle membrane or the muscle membrane beyond the perijunctional zone. And in this way, the perijunctional zone is going to act as a buffer. And this process is known as accommodation. And this is the reason why succinylcholine, despite producing persistent depolarization at the motor end plate, is going to produce neuromuscular paralysis. So this is a very, very important concept of how succinylcholine produces muscle paralysis. Now, let us talk about the pharmacokinetics and pharmacodynamics of succinylcholine. Now, if you talk about the onset, before actually talking about the dose of succinylcholine, it is very important to understand a concept of ED95. ED95 stands for effective dose 95. What does this mean? Effective dose 95 means it is that dose of the neuromuscular blocking drug that causes 95% depression in twitch height. So when you are measuring a single twitch response in neuromuscular monitoring, this is the stimulus and this is the response to that stimulus. So this is the control, that is before you have given any neuromuscular blocking drug, and this is the point where you already have given the drug, and the point or the dose at which there is 95% depression in twitch height. This is known as the effective dose 95 of that drug. Why is this important? So it is important for two things. First is, higher the ED95, less is the potency. Just to give you an example, the ED95 of atracurium, which is a non-depolarizing muscle relaxant, is 0.2 milligrams per kg. and that for cis-atracurium, it is 0.05 milligrams per kg. So as you can see, atracurium has a higher ED95, cis-atracurium has a lower ED95. So which one is more potent? It is cis-atracurium. This is more potent than atracurium. So one is the estimation, or we can know the potency of the neuromuscular blocking drug if we know the ED95. The second thing is the intubating dose. Because one of the most important reasons why we give neuromuscular blocking drugs is to intubate the patient. We need vocal cord paralysis in order to intubate the patient. You can give, or rather, neuromuscular blocking drugs are indeed given for surgical muscle relaxation as well, in order to increase surgical exposure and increase the surgical field. But the primary importance for the anesthesiologist for giving neuromuscular blocking drugs is to provide adequate intubating conditions. That is very, very important. And you can actually intubate a trachea without the use of neuromuscular blocking drugs, but you have to use induction agents, either inhalational or IV induction agents such as propofol, plus very, very high doses of opioids, which have side effects of their own. So if you do not want to use neuromuscular blocking drugs, as can be due to a number of diseases where you don't want to use neuromuscular blocking drugs, so you can provide intubating conditions with very, very high doses of opioids, but those obviously carry their own side effects. And there have been several studies that have been done that have consistently shown that the incidence the incidence of vocal cord lesions is very high when you don't use a muscle relaxant. Also, it was found that the incidence of encountering difficult intubation and the incidence of encountering Cormack and Lehan grades 3 and 4, these were also very high when muscle relaxants were not used. So as you can see, it is very, very important to use muscle relaxants in order to provide adequate intubating conditions. So we have to know the intubating dose of different muscle relaxants. Now, classically, the intubating dose should be 2 to 3 times, at least 2 to 3 times the ED95 of that drug. So I'll just make a small little table, and I'll just enumerate the various ED95s and the corresponding intubating doses of some of the commonly used neuromuscular blocking drugs. ED95 in milligrams per kg, and the intubating dose again in milligrams per kg. So in case of succinylcholine, the ED95 is 0.3 mg per kg. Therefore, the intubating dose, which is 3 times the ED95, becomes 3 multiplied by 0.3, it is 0.9. So around 1 mg per kg. For atracurium, it is 0.2 mg per kg, and the intubating dose becomes 0.5 to 0.6 mg per kg. For cis-atracurium, it is the ED95 is 0.05, and the intubating dose is somewhere around 0.15 to 0.2 mg per kg. For vecuronium, the ED95 is the same as this atracurium, and the intubating dose is 0.1 to 0.15 mg per kg. For rock or rocuronium, it is the same as succinylcholine, the ED95, but the intubating doses for rocuronium, we can use 3 different doses depending on how fast we want to achieve the intubating conditions. So we can use the intubating doses ranging from 0.6 mg per kg all the way up to 1.2 mg per kg. Right, we also have mevacurium, which has an ED95 of 0.08 mg per kg. Gantacurium has an ED95 of 0.19 mg per kg. So this is quite important even from exams point of view to know the concept of ED95 and intubating doses as well. So what about the onset of succinylcholine? So succinylcholine, why was succinylcholine so popular in the first place? There were 2 major advantages of succinylcholine. One was its very, very fast onset of action. and the second was its very short duration of action. So fast onset of action, where would this property be beneficial for an anesthesiologist? In cases where there is a high risk of aspiration. So whenever we intubate the patient, we give some drugs such as inhalational agents or IV agents that are going to blunt the consciousness. So we are essentially putting the patient in a reversible coma with anesthetic agents, and then we intubate the trachea. But the off chance of that is that once the consciousness is depressed, the patient will not be able to protect their own airways, because all the protective airway reflexes will also be suppressed or abolished. And therefore, if during that time, post-induction, if the patient happens to regurgitate gastric contents, there is a very high risk of those regurgitant contents going into the trachea and causing aspiration pneumonitis, which is obviously a very, very bad thing for the patient to happen. So there are certain patient populations that have an inherently high risk of aspiration, such as long-term diabetic patients because of autonomic dysfunction, GERD patients because of incompetent lower esophageal sphincter tone, patients who have increased intra-abdominal pressure, such as in pregnancy, obesity, ascites, etc. These patients have high risk of aspiration. So naturally, we would want our muscle relaxant to act very, very quickly. For example, if you've given propofol and you have given a non-depolarizing muscle relaxant such as atracurium, which takes around 3 to 4 minutes to attain peak effect, during this time, if the patient regurgitates, because during this time, the patient's airway has not been secured. So if the patient happens to regurgitate, there will be a risk of aspiration. In contrast, if you give scoline to the patient, you can achieve intubating conditions within 60 seconds of giving a dose of 1 milligram per kg, which is the intubating dose. So naturally, you would prefer succinylcholine in cases of high risk, where there is a high risk of aspiration, because it produces relaxation of the vocal cords so quickly, and you can intubate the trachea that much faster, thus eliminating the risk of aspiration. The second property of succinylcholine is the short duration of action. So this is also very, very important. But where would this be important? It would be important in difficult airway. If you encounter an anticipated or unanticipated difficult airway, you naturally do not want to give a long-acting muscle relaxant in order to intubate the patient, because what if? So those what if scenarios are very important here. What if you cannot intubate the patient due to some reason? What if that happens? What if, even worse than that, you cannot even ventilate the patient? Right? So you have given propofol to the patient. In about 25% of patients who receive induction doses of propofol, they experience apnea. Let us suppose you thought that the patient is now induced and you gave atracurium to the patient after giving propofol, and you did not check that the ventilation of the patient, if you were able to ventilate the patient with a bag and mask, and you gave atracurium, and then you come to realize that, oh no, I cannot ventilate this patient. Then you hurriedly try to intubate the patient, but oh no, the CL grading was 4. You cannot even see the vocal cords. Well, you cannot intubate. You called for help. Even let us suppose your experienced anesthesiologist was also not able to intubate the patient. You cannot intubate, and you tried various methods of ventilating the patient. You tried inserting the supraglottic airways. Let us suppose that also did not work, so you weren't able to ventilate the patient as well. And you've given atracurium. Now, the duration of action of atracurium is around 45 minutes if you have given an intubating dose of 0.5 mg per kg. So, do you think the patient will be able to sustain periods of apnea for 45 minutes? Obviously not. The patient will become hypoxic and the patient will die. But what if you gave succinylcholine to this patient? If succinylcholine was given to this patient, the duration of action of succinylcholine is anywhere from 9 to 13 minutes. And on an average, let us say 10 minutes. So the patient will come out of paralysis within 10 minutes. And it is very much possible for the patient to tolerate a period of apnea for 10 minutes, provided they had been adequately pre-oxygenated. So this is the preconditioning I'm associating with this. If they had been adequately pre-oxygenated, the apnea time increases from around 2 to 3 minutes under normal circumstances to around 8 to 10 minutes in healthy individuals, provided they are not pregnant, not obese, do not have underlying respiratory mechanics issues. So if they had been adequately pre-oxygenated, they could tolerate a period of apnea for 10 minutes, and then they would come out of the paralysis and start breathing on their own. So that is why succinylcholine is very, very important in difficult airways. When you encounter difficult airway, even if you know that the patient already has a difficult airway based on your pre-anesthetic checkup, those are called anticipated difficult airways, but you may very well have had done the PAC, you did not find any abnormalities in the airway examination, but still after induction you encounter difficulty in either ventilating or intubating or both in the patient. So that is known as an unanticipated difficult airway. So in both the situations, succinylcholine is very, very important and oftentimes a life-saving drug in these situations. So that is why succinylcholine was so popular, and essentially it still is popular, especially in situations and in settings where rocuronium is not available. Succinylcholine is still being used for rapid sequence intubation in case of high risk of aspiration, that is called RSI, or in cases of difficult airway. Right, so that was the onset of succinylcholine, around 30 to 60 minutes. So within 60 minutes, you will be able to achieve adequate intubating conditions. We talked about the duration of action for succinylcholine, which was 9 to 13 minutes on an average. And now we will talk about the metabolism of succinylcholine. So succinylcholine is not dependent on any organ for its metabolism. Almost 98 to 99% of succinyl metabolism happens by butyryl cholinesterase, which is also known as pseudocholinesterase enzyme. And it is present in plasma. That is why it is also called as plasma pseudocholinesterase. So what happens is, let us suppose this is blood and this is the effect site. So this is the blood or the plasma, whatever you want to call it, and this is the effect site of scoline, which is the neuromuscular junction. So let us assume you gave a IV bolus to the patient. There will be an increase in the concentration of succinylcholine in the blood, and this will create a concentration gradient between the plasma and the effect site, and naturally succinylcholine is going to travel down its concentration gradient and reach the effect site and cause depolarizing block. Right, now the duration of action of succinylcholine will depend on how fast it is being cleared from the plasma, because until and unless the concentration in the plasma starts to fall, this concentration gradient cannot be reversed. It is only when plasma pseudocholinesterase enzyme starts to break down succinylcholine in the plasma that the concentration of succinylcholine in the plasma falls. This concentration gradient is reversed and scoline then moves out from its effect site into the plasma to be attacked by plasma pseudocholinesterase. In this way, succinylcholine gets metabolized, right? What about the metabolic essentially your products of metabolism? So succinylcholine gets metabolized to succinyl monocholine and then choline. These do not have a very significant neuromuscular blocking property, and they eventually are excreted out in the urine. Now there are certain conditions where the activity of pseudocholinesterase enzyme is decreased. And these conditions are important because a decrease in the activity of pseudocholinesterase will clinically mean that there will be a decreased metabolism of succinylcholine, and therefore it will remain the effect site for a much longer period of time, thus producing clinically longer paralysis than the usual 10 minutes that we see. So what are those conditions? So there are some conditions such as old age. It is associated with decreased production. The site of production of pseudocholinesterase is naturally liver, just like many other plasma proteins. This protein is also synthesized in the liver. So old age is associated with a decreased production of pseudocholinesterase enzyme. Liver disease, advanced renal disease, pregnancy, malnutrition, certain drugs such as MAO inhibitors, monoamine oxidase inhibitors, oral contraceptive pills, even your certain cytotoxic anti-cancer drugs, even cancer itself, neoplastic disease. Most importantly, anticholinesterase drugs. For example, neostigmine, ecothiopate. So neostigmine, these are acetylcholinesterase inhibitors. Neostigmine is used as a reversal agent in case of non-depolarizing muscle relaxants, whereas ecothiopate is used in the treatment of glaucoma. So these drugs, they not only inhibit acetylcholinesterase, they also inhibit pseudocholinesterase or butyrylcholinesterase, thus decreasing its activity. Even drugs like metoclopramide, which we use very, very commonly in anesthesia, right? Sometimes we don't even think about all the side effects of metoclopramide, provided this particular side effect is not clinically relevant, but still, we think of it as a very benign sort of a drug, but it has been associated with QT prolongation, arrhythmias, bradycardia, etc. So even while giving a very basic drug such as metoclopramide, you should be aware of its pharmacology. Bambuterol is a drug which is actually a precursor or a prodrug of the beta agonist terbutaline, which is used in the treatment of asthma. So this also inhibits pseudocholinesterase. Drugs such as esmolol, that also inhibits pseudocholinesterase, right? So in most of these conditions, the decrease in the activity of pseudocholinesterase enzyme is not clinically significant, right? Because it has been found that it takes a lot of, it takes a significant reduction in the pseudocholinesterase activity for succinylcholine paralysis to be clinically prolonged. In most cases, there is a very small prolongation. For example, in case of advanced cirrhosis, where the liver is shot to hell, the pseudocholinesterase activity is reduced to around 20% of the baseline. So I'm talking about pseudocholinesterase activity. It is 20% of the baseline in advanced cirrhosis. Even in this such an advanced cirrhotic state, essentially the recovery or the duration of apnea which is produced by succinylcholine is only prolonged from 3 minutes to 9 minutes. So not clinically very significant, right? But which conditions are associated with a clinically significant prolongation of succinylcholine paralysis? And that is where your genetic variations of this enzyme come into play. Genetic variations of plasma pseudocholinesterase enzyme. So each of us have 2 copies of plasma pseudocholinesterase. Let us suppose the red denotes the normal allele and the green one denotes the mutant or the abnormal allele. So if both the copies of the allele are normal, then this is obviously the normal variant. In this case, the plasma pseudocholinesterase activity is also normal and the effect of scoline is also normal. But what about a situation where one of the alleles was mutated? So, but the other one is healthy. So this is heterozygous condition. Here the plasma pseudocholinesterase activity is slightly reduced and the effect of scoline is found to be that it only causes prolongation by 50 to 100%. That means maybe if the normal duration of action was succinylcholine was around 7 minutes, then it will be prolonged to 100%. That means twice of that, so around 14 minutes. So not much prolongation. But the most disastrous of the situations is where there was an undiagnosed case of homozygous variant of the homozygous case of the pseudocholinesterase allele where both the alleles were mutated. So this is homozygous for the mutant allele. So here the pseudocholinesterase activity is very, very much reduced, and the effect of scoline paralysis can be as long as 4 to 8 hours. So normally the patients would come out of paralysis within 10 minutes, but now you can see the patient is paralyzed after just a single intubating dose of succinylcholine. If they have this homozygous mutant trait, they will be paralyzed for 4 to 8 hours. So what to do if you encounter such a situation? If you encounter such a situation, then there are only two things you can do. You can sedate the patient and continue mechanical ventilation. So you have to shift the patient to the ICU in the post-op period. Naturally, you have to keep the patient sedated because they will be paralyzed. And if you do not sedate them, that is essentially just same as torture. The patient is paralyzed, but they are aware, they are awake. So you have to sedate the patient, continue mechanical ventilation, and extubate the patient when the effects of succinylcholine have passed. And that is the only management of succinylcholine, prolonged succinylcholine paralysis by a diagnosed case of or known case of pseudocholinesterase deficiency. So how can you estimate? Either you can measure plasma pseudocholinesterase activity, but that obviously requires blood samples and all of that and specialized tests to do that. There is another way that you can do it, and that is by estimating the Debukine number. So Debukine is actually a local anesthetic, and normally it inhibits the pseudocholinesterase enzyme. So under normal circumstances, the percentage inhibition of pseudocholinesterase by Debukine is more than 80%. So more than 80% of pseudocholinesterase is inhibited by Debukine. If it is less than 20%, then that means that the patient has homozygous mutant alleles and should never be given succinylcholine. If it is between 80 to 20%, then that means they have varying degrees of heterozygosity. So this is also very, very important thing to keep in mind regarding the normal enzyme and abnormal enzyme. So now let us talk about some of the side effects that are associated with succinylcholine, because I already talked about the advantages, which are fast onset, short duration. But what are these some of the important side effects of succinylcholine use? So first, let's start with the cardiovascular side effects. Now, as I already mentioned, succinylcholine is going to interact with nicotinic acetylcholine receptor. I mentioned in the previous lecture that there are two types of nicotinic acetylcholine receptors. We had the NM type, which were located in neuromuscular junction, and the NN type, which were located in the autonomic ganglia, both in the parasympathetic ganglia as well as the sympathetic ganglia. So scoline is essentially an agonist at these receptors. So in addition to providing agonistic activity at the neuromuscular junction, which eventually results in paralysis, it also interacts with the sympathetic and parasympathetic autonomic ganglia. So at low doses, it mostly stimulates the parasympathetic ganglia. And this produces fall in heart rate and a fall in systemic vascular resistance. Right? This fall in heart rate is because of stimulation of parasympathetic outflow, which increases parasympathetic stimulation of the heart. So we know that if, let us suppose this is the heart, these are the atria and these are the ventricles, the parasympathetic supply mostly comes and goes to the SA node and it goes to the AV node, and this is via the vagus nerve. But the sympathetic supply is present all over the heart. Parasympathetic supply is usually present above the ventricles. It is not present at the ventricles, but sympathetic supply is present all over the heart. So changing the vagal tone mostly changes the heart rate, whereas changing the sympathetic tone can change both the heart rate, as that is known as chronicity, and also chronotropy, and it also can change the strength of contraction of the heart, which is known as inotropy. So at low doses, there is parasympathetic stimulation which produces a fall in the heart rate. But succinylcholine does not cause bradycardia by this mechanism only. There is another mechanism which causes succinylcholine induced bradycardia. So I talked about cholinergic receptors in the last lecture, and there were two types of cholinergic receptors. We had I should write it over here. The cholinergic receptors were of two types. One were the nicotinic receptors, and the other ones were muscarinic receptors. Now, succinylcholine, because it resembles acetylcholine so much, it not only interacts with the nicotinic receptors, both at the neuromuscular junction and the ganglia, it also interacts with the muscarinic receptors as well. So, in the heart, we know that there are M2 receptors present on the SA node and the AV node. So, the direct stimulation of cardiac M2 muscarinic receptors is responsible for the bradycardia produced by succinylcholine. But at very, very high doses, the sympathetic autonomic ganglia might be stimulated, which can result in tachycardia, hypertension. Right? So these are the cardiovascular effects. What are the major cardiovascular side effects that are clinically relevant to us when we are talking about scoline? So scoline can cause one effect I've already mentioned, that is bradycardia, sinus bradycardia. It can also lead to nodal or junctional rhythm. And it can also cause ventricular dysrhythmias. So the cause of sinus bradycardia we have already talked about. It can cause bradycardia by parasympathetic stimulation as well as the direct stimulation of the cardiac muscarinic receptors. Also, it has been found that the sinus bradycardia which is produced by succinylcholine can happen in two instances. One is when we are dealing with children. In children, even the first dose of succinylcholine can cause bradycardia. Therefore, when you are giving a succinylcholine in children, even though routine use of succinylcholine in children should be avoided, but if you have to give succinylcholine to a child, even before giving the first dose of succinylcholine, you have to give a prophylactic dose of atropine, which is a very potent anticholinergic, and it blocks the M2 receptors and therefore does not allow scoline to stimulate those M2 receptors and cause bradycardia. Second situation is when we are dealing with adults. So in adults, it has been found that it is not the first dose, but it is the repeated dosing with succinylcholine that is going to cause brady. So if you are dealing with adults and you need to give a second dose of succinylcholine, then you should give atropine. Right? Usually we do around 20 micrograms per kg. So what about nodal or junctional rhythms? So naturally, if the bradycardia that is produced by succinylcholine is so severe that the SA node is depressed to a significant extent, then the pacemaker of the heart will be taken over by the AV node, and naturally the intrinsic frequency of AV node firing is around 50 to 60. So how can you differentiate between sinus bradycardia and nodal bradycardia? So sinus bradycardia, you will be able to see a distinct P wave with a normal morphology. So that means that the origin of this depolarization wave is the SA node. But in nodal rhythms, there will be no P wave. So that means that it is originating from the AV node, but the QRS complexes will still be narrow. then it can also cause ventricular dysrhythmias. There have been several studies done in monkeys and dogs and whatnot that showed, however, this actually, I would be very wary of just blankly stating that succinylcholine can cause ventricular ectopics or dysrhythmias, because there are so many other confounding factors that have been associated. For example, it was found that succinylcholine decreased the threshold of epinephrine-induced ventricular dysrhythmias. But you have to keep in mind that succinylcholine is not just given in an isolated form, right? Along with succinylcholine administration, there is also laryngoscopy that is being done. There is intubation that is being performed. There might be hypoxia, there might be hypercarbia, there might be use of halothane, which is known to sensitize the myocardium to the arrhythmogenic effects of epinephrine. So there are so many confounding factors that can contribute to the development of ventricular ectopics. But yes, you can keep this in mind that administration of succinylcholine can be associated with the appearance of ventricular ectopics or ventricular arrhythmias. And also in cases of severe depression of SA node and AV node, there might actually also be ventricular escape rhythms might also be seen. And the next side effect that we are going to talk about also binds into it is hyperkalemia, because hyperkalemia by itself can also cause ventricular ectopics and ventricular dysrhythmias. So hyperkalemia produced by succinylcholine may then in turn cause ventricular dysrhythmias. So now let's talk about hyperkalemia, which everyone is scared of while using succinylcholine. So under normal circumstances, we know that the normal range of serum potassium is 3.5 to 5.5 milliequivalents per liter. Under normal circumstances, if you have given a single intubating dose of succinylcholine, the increase in serum potassium is only by 0.5 milliequivalents per liter. So if before giving succinylcholine it was 4, now it is 4.5. And a very, very important thing I would like to tell, and that you should always remember, is that scoline or succinylcholine can be given in patients of CKD or chronic kidney disease. You can give succinylcholine in these patients, but there is a condition: provided that their potassium is within normal range. Because I'll give you a clinical scenario. A lot of the times, patients with chronic kidney disease who have to undergo some sort of operation or whatnot, they do suffer from delayed gastric emptying. They have delayed gastric emptying, and therefore they are at high risk of aspiration. And very often, RSI is done in patients with CKD who are undergoing surgery. And a very, very vital drug for RSI is essentially scoline. Yes, you can also use rocuronium, which is now used nowadays instead of scoline, because it provides very, very fast intubating conditions, just like succinylcholine, but none of the side effects of succinylcholine. So you can use rocuronium, but in situations where you do not have the availability of rocuronium, and the prerequisite of using rocuronium is also the availability of Sugammadex. You have to have Sugammadex in case you need to rapidly reverse the patient, especially in cases of difficult airway, because patients of CKD might have osteolytic lesions, especially they could have a rubber jersey spine and whatnot, so their airway might also be difficult. So you might be using scoline for that purpose also. And if you are using rocuronium instead of scoline, don't think that it is entirely safe, because if Sugammadex is not available, then there is no point in giving rocuronium. You won't be able to reverse rocuronium quickly enough. You need Sugammadex for rapid reversal of rocuronium. The other condition is that the safety of Sugammadex in patients with renal failure has not been established, right? So let us suppose there was a patient of CKD, you gave rocuronium to the patient, but now you are unable to intubate and unable to ventilate, and you want to rapidly reverse the patient. And just after giving rocuronium, the dose for Sugammadex for rapid reversal is 16 milligrams per kg. And giving such high, and the elimination and clearance of Sugammadex is entirely based or dependent on kidneys. So the safety of using Sugammadex in a patient with chronic kidney disease with GFR less than 10 ml per minute, it is not established. So all I'm trying to say is scoline is still being used in patients with CKD, and you should not be afraid of using scoline for the fear that it might precipitate hyperkalemia. If the CKD patient's potassium is within the normal range, you can safely use succinylcholine in such patients. The other thing is that which conditions are associated with severe hyperkalemia if you give succinylcholine. So succinylcholine is associated with severe hyperkalemia in two very, very important conditions, which are, there are a lot of conditions that might predispose the patient to developing hyperkalemia. For example, burns, trauma, rhabdomyolysis, and whatnot. But the two most commonly and clinically important situations, which you, I'm sure, will encounter either in your clinical critical care rotations or just when you're dealing with critically ill patients, is severe metabolic acidosis and hypovolemia. So these are not the two conditions that immediately come to mind when we are talking about hyperkalemia precipitated by scoline. But these are very, very important conditions that frequently lead to severe hyperkalemia after succinylcholine administration. Because it has been seen that in severe hypovolemia and metabolic acidosis, the source of potassium after giving scoline is not the muscle, skeletal muscle. It is not the skeletal muscle, but rather it is the gut. Gut muscle is there, or gut. So gut is the source of potassium release into the bloodstream in case of severe metabolic acidosis and hypovolemia. One thing that I forgot to mention is, why does hyperkalemia happen? So I already mentioned that there are two types of nicotinic receptors, the mature and the immature, or the extrajunctional. The mature receptors are only present at the end plate, where the immature receptors are present everywhere. Now what happens is, when you give succinylcholine, and it is going to interact naturally at the mature receptors at the end plate, but it will cause persistent opening of these channels. Now the ligand-gated channels, nicotinic channels, are not only sodium channels. They don't only allow conductance of sodium, but the conductance in the nicotinic acetylcholine receptors is also for potassium. And the conductance for sodium and potassium is equal, and that of calcium is slightly lower than these two. But it allows all three ions to cross through. And sodium moves inside the cell, whereas potassium moves outside the cell during the state when it is opened, the receptor is opened. But since succinylcholine produces persistent opening, there is a lot more time for potassium to leak out into the bloodstream. And this produces the hyperkalemia that we see with succinylcholine. So in certain situations such as burns and denervation injuries, spinal cord injuries, your muscular dystrophies, especially Duchenne muscular dystrophy, and certain neuromuscular junction disorders such as myasthenia gravis or Guillain-Barré syndrome, all of these situations are going to have increase in the expression of immature receptors, and that is going to produce life-threatening hyperkalemias. So before the administration of succinylcholine in such situations like hypovolemia and severe metabolic acidosis, correction of said abnormalities might be prudent before administering succinylcholine, right? So either you might have to hyperventilate the patient or use sodium bicarbonate depending on the clinical situation before you administer succinylcholine. However, if hyperkalemia does occur after administration of succinylcholine, so naturally those ECG changes will start to happen, right? There will be bradycardia, there will be widening of the PR interval, there will be widening of QRS complex, tall tented T waves, which is the earliest ECG sign of hyperkalemia. This will eventually progress to sine wave pattern, ventricular ectopic sine wave pattern, and eventually cardiac arrest. Right, so if that happens, hyperkalemia occurs, then you need to rapidly treat it. So you need to give 500 mg to 1 gram of calcium gluconate or calcium chloride. Right, that I'm sure you all know by now, though, that 10%, 10 ml calcium gluconate over 2 to 3 minutes, right? That this acts as like a membrane stabilizing agent and prevents the prevents the dysarrhythmias that are caused by hyperkalemia. Then you also need to institute potassium lowering therapies, such as you need to give 50 ml of 50% dextrose, and you have to neutralize it with 10 units of regular insulin. Excuse me. In case of children, you might require 0.15 units per kg of regular insulin in children. This is in adults. So in children, you might require 0.15 units per kg of regular insulin along with 0.1 ml per kg of 50% dextrose. If you don't have 50% dextrose, which oftentimes we don't, then we can just neutralize 1 bag of that is 500 ml of 5% dextrose with 8 to 10 units of regular insulin, or you can neutralize one bag, that is around 100 ml of D25% with the same 8 to 10 units of regular insulin. So you need to institute potassium lowering therapies, and you also need to stabilize the myocardium with the use of calcium gluconate. So the increase in serum potassium, as I already said, normally is around 0.5 milliequivalents per liter, but it has been found that in severe abdominal infections, abdominal sepsis, or severe abdominal infections, especially those that have persisted for more than 1 week, the rise in serum potassium can be as high as 3.1 milliequivalents per liter. Right, so naturally very, very high risk of hyperkalemia. Similarly, trauma, physical trauma. So the risk of hyperkalemia after significant physical trauma starts to appear or starts to increase after 1 week of trauma. And the patients can be susceptible for hyperkalemia till as long as 60 days after the initial traumatic event, or till complete recovery of the injured muscle has taken place. So all of these things have to be kept in mind regarding hyperkalemia that is produced with succinylcholine. Succinylcholine also leads to increase in intraocular pressure. So the normal intraocular pressure is somewhere around 10 to 20 millimeters of mercury. One thing to keep in mind is, why does intraocular pressure increase? It's a very interesting phenomenon, I'll tell you in a second. So why does this increase in intraocular pressure takes place? So this takes place because the eyeball is surrounded by a host of extraocular muscles. Right. Now, a very, very peculiar thing about these extraocular muscles is that they do not show accommodation. And I'm not talking about accommodation from an ophthalmological point of view. I'm not talking about the power of accommodation. I'm talking about the accommodation that we discussed at the start of the lecture. That was the accommodation shown by perijunctional zone of the skeletal muscle, which allowed this zone to act as a buffer and prevent any depolarization waves produced by succinylcholine to travel to the sarcolemma, adjacent muscle membrane. That is not shown by extraocular muscles. And they also have, so one is this. Second thing, peculiar thing about extraocular muscles is that they have very high density of fetal or the immature type of nicotinic acetylcholine receptors. All of these factors contribute to sustained contractions of the extraocular muscles, which can lead to increases in intraocular pressure. Right? So the increase in intraocular pressure develops within 1 minute of administration of succinylcholine. It peaks at around 2 to 4 minutes, and then it subsides within 6 minutes of administration. So even though succinylcholine does tend to increase the intraocular pressure, its use is not contraindicated in eye surgeries. It is not it can be used in eye surgeries. But the only condition is that the anterior chamber should not be open. Another thing that you can do is that in order to prevent the fasciculations and sustained contractions that happen because of succinylcholine administration, you can administer a prior dose of a non-depolarizing muscle relaxant. This is known as a defasciculating dose of depolarizing muscle relaxant, which is taken to be around 20% of the ED95 or around 10% of the intubating dose. For example, if you need to give ATRA before succinylcholine in order to prevent fasciculations, we know that the normal intubating dose of atracurium is around 0.5 mg per kg. So 10% of 0.5 will be 0.1 into 0.5. So that is 0.05 mg per kg. Right? So in case of a 60 kg man, it will be around 3 mg. So you can give 3 to 5 mg of atracurium 3 to 4 minutes before you give succinylcholine. Then you won't be seeing those fasciculations that are seen because of succinylcholine administrations, which are because of discoordinated muscular contractions. So that is called defasciculating dose of non-depolarizers. Those can be given before you give scoline in order to prevent increases in intraocular pressure. Also, the use of succinylcholine in patients with penetrating eye injuries after pre-treatment with a non-depolarizing neuromuscular block and with a carefully controlled rapid sequence induction of anesthesia is very much allowed. So you can use succinylcholine. A lot of the times these patients come in emergency and they do not have adequate fasting intervals, and you cannot wait also in order to keep them fasted for a long period of time, because these are time sensitive surgeries, or rather emergent surgeries. Sometimes they have to be done within 2 hours, 3 hours. So you cannot wait for the patient to become fasted. You have to do rapid sequence intubation, and you can use succinylcholine provided you use a defasciculating dose. Or if you don't want to use succinylcholine, you can definitely go ahead with rocuronium, which is a non-depolarizer. Another thing that you need to keep in mind is that the increase in intraocular pressure by just using succinylcholine is not so much of an issue. But the issue is that if you attempt to intubate the patient by giving submaximal doses of succinylcholine, or if you gave a non-depolarizer and did not allow for enough time for full vocal cord relaxation, and if you try to intubate in a partially paralyzed patient, that will lead to coughing, it will lead to bucking, it will lead to forceful closure of eyelids. Naturally, the patient will be uncomfortable, so they will grimace, they will close their eyelids, they will cough, they will buck, right? And all of these things will lead to a very, very high increase in intraocular pressure, even higher than what is seen with just giving succinylcholine. So your intraocular pressure can reach almost 60 to 90 millimeters of mercury from the normal 10 to 20 millimeters of mercury. So isn't it better to use succinylcholine and ensure that the intubating conditions are perfect and the depth of anesthesia is adequate before you go about intubating the patient? What the other side of it would be to not use succinylcholine and to attempt intubation in a partially paralyzed patient or subparalyzed patient, and then risk having them cough, buck, and eventually increase intraocular pressures to detrimental levels and cause extrusion of the vitreal contents or eye contents. So that, in my opinion, would be even worse than just using succinylcholine. So another thing that succinylcholine does is it also increases intragastric pressure. But in contrast to intraocular pressure, increases in intraocular pressure, which are pretty consistent. So it has been consistently found that succinylcholine does indeed increase the intraocular pressure. The increases in intragastric pressure with succinylcholine are not very consistent. Sometimes there is an increase, other times there might not be. And the mechanism that has been implicated is fasciculations of the abdominal muscles. Fasciculations of abdominal muscles. Right? And the intensity of increase in intragastric pressure is directly related to the intensity or the duration of fasciculations of the abdominal muscles. And if you prevent the fasciculations of abdominal muscles by using the same principle of defasciculating, giving defasciculating dose of a non-depolarizer, then the increase in intragastric pressure is also not seen, right? So normally what happens is, if this is your esophagus, let us assume, and that is your stomach, this is your lower esophageal sphincter. Now, it has some intrinsic tone that prevents the contents of the stomach to travel upwards into the esophagus. But it depends on the intragastric pressure. If the intragastric pressure becomes more than 28 centimeters of water, then this intrinsic tone of lower esophageal sphincter is overcome and the intragastric contents can go up into the esophagus. This is normally what happens. But there are certain situations where there is an alteration in the lower esophageal sphincter tone. Right? For example, pregnancy or ascites. Here, if your intragastric pressure, because of actually changes in the angle between the stomach and the esophagus, even increases of intragastric pressures beyond just 15 centimeters of water will lead to incompetency of lower esophageal sphincter and may lead to regurgitation. So if you suspect that the patient might have an altered lower esophageal sphincter tone, then you can use aspiration prophylaxis, pharmaceutical prophylaxis by using metoclopramide and such, ranitidine and all. You can use them, precautionary measures. Although, the increase in intragastric pressure from succinylcholine is well documented, its evidence of clinical harm is not clear. So we're not sure whether it does really impact all that much the clinical scenario of succinylcholine, right? And the succinylcholine does not really significantly increase the intragastric pressure in children or infants. It also leads to an increase in the intracranial pressure, or ICP. Right, and again, by pre-treatment with a non-depolarizer, this increase in ICP can be prevented. Another very, very common side effect that is reported with succinylcholine use are post-op myalgias. The incidence actually varies a lot. So the incidence varies from as little as 0.2% to as high as 89%. And it has been seen that the incidence of post-op myalgia is much more frequent in minor surgeries rather than major surgeries. In minor surgeries and in certain patient populations, such as women and those undergoing or those patients who are ambulatory. So the frequency of myalgias is actually less in bedridden patients because they have an overall less lean mass. Right, and what is the cause of myalgia? So it is essentially due to damage which is produced in the muscle by unsynchronized contraction of adjacent muscle fibers. I don't know if if you are a resident or you're an anesthesiologist, you obviously have seen the disorganized contractions. But if you're an intern or an MBBS student, you might have seen the disorganized fasciculations that are produced by succinylcholine, right? The face muscles start to fasciculate, and then the fasciculations travel down the body and eventually reach the tips of the toes. So that disorganized contraction of different muscle fibers can actually produce damage in those fibers and lead to development of post-op myalgias. So that is one mechanism. Another mechanism, it was found that when these operative patients were treated with your prostaglandin inhibitors and your COX inhibitors like non-steroidal inflammatory drugs, so prostaglandin inhibitors and COX inhibitors, when these drugs were given to the patients, there was a reduction in the incidence of myalgias. So that means that prostaglandins and cyclooxygenases also have some role to play in succinyl-induced myalgias. Another important thing to keep in mind is masseter muscle rigidity. So obviously, just like other skeletal muscles, succinylcholine is also going to cause increase in the tone of the masseter muscle. However, and another thing to keep in mind is that masseter muscle, increase in the tone of masseter muscle, or which is known as masseter muscle rigidity or spasm, is one of the earliest signs of malignant hyperthermia. And malignant hyperthermia is a very, very dangerous situation. It is a life-threatening clinical emergency. And succinylcholine has been identified as one of the triggers of malignant hyperthermia. However, even if the patient starts to develop an increase in the tone of masseter muscle after succinylcholine administration, it does not mean that they are developing malignant hyperthermia. Right? So an increase in tone of the masseter muscle may be an early indicator of malignant hyperthermia, but this finding is not consistently associated with that syndrome. So masseter muscle rigidity is not just found in malignant hyperthermia. It can be because of just simple administration of succinylcholine, right? So you do not have to get scared after giving succinylcholine and the patient developing spasm of the masseter muscle that there is an imminent malignant hyperthermia. Yes, you should always keep your eyes and ears open. Your clinical judgment should always be sound. And you should be able to identify if the patient is indeed developing malignant hyperthermia, but just using succinylcholine and seeing masseter muscle spasm does not mean that they are developing malignant hyperthermia. There is also a very small incidence, about 0.06% incidence of anaphylaxis with succinylcholine. And most of these cases actually are reported from Europe and Australia only, not from India. or Asia. There might be some evidence of cross-reactivity with other non-neuromuscular blocking drugs as well. So these were all the side effects of succinylcholine. What about the clinical uses of succinylcholine? I already talked about two very, very important clinical uses of succinylcholine. One was the rapid sequence intubation, or RSI. Right? So we use 1 mg per kg of succinylcholine. RSI is essentially a technique where you want the smallest amount of time between the loss of consciousness after induction of anesthesia and securement of the airway with a cuffed endotracheal tube. There should be as little time as possible in between these two. And that can only be done with either succinylcholine or rocuronium. I mean, you can also get, usually like within 60 seconds, you will be able to achieve intubating conditions. Now, you can actually hasten the onset of a non-depolarizing muscle relaxant like Atra also, if you use high enough doses. For example, if you use 1.5 mg per kg of atracurium instead of the usual 0.5, so 3 times as much as atracurium, you can actually intubate the patient within 60 seconds. But the side effects that accompany with that high of a dose are unacceptable. There have been instances with sudden bradycardia and cardiac arrest following rapid administration of high dose of atracurium. So you cannot just use any non-depolarizer at a high enough dose to hasten the onset time, right? So either you can use succinylcholine or you have to use rocuronium. Prior administration of acetylcholine also succinylcholine enhances the depth of blockade, which is caused by a subsequent dose of non-depolarizing muscle relaxant as well. For example, if you are using atracurium for induction, then the effect may last anywhere from 30 to 40 minutes. But if you initially gave succinylcholine and then you gave atracurium, then the effect may be prolonged to 40 to 50 minutes. So it does enhances the depth of blockade and also the duration caused by a subsequent dose of non-depolarizing neuromuscular blockade. Another thing to be kept in mind is that if you use very large doses of succinylcholine, then the type of block that is produced can change from a normal phase 1 block, which is the depolarizing block produced by succinylcholine, which we talked about in the previous lecture, and we will also talk about it in a subsequent lecture on neurological monitoring. It changes from phase 1 to phase 2 block, which starts to resemble a block produced by a non-depolarizing relaxant, as characterized by the presence of fade and post-tetanic potentiation. Right? So this has to be kept in mind. What about its interactions with the rapid sequence? Apart from rapid sequence intubation and difficult airway, you should not use succinylcholine routinely, as is evidenced from a list of these side effects that I already talked about, right? From hyperkalemia to arrhythmias to IOP, ICP increase and whatnot, myalgias. So routine use of succinylcholine should be discouraged, but you should not hesitate to use succinylcholine in situations where it is required, such as rapid sequence intubation and difficult airway, in case you do not have access to rocuronium. So succinylcholine can also lead to interactions with other drugs as well. So what if you give succinylcholine with an anticholinesterase inhibitor? For example, neostigmine. I'll give you a clinical scenario here. Let us assume you got a patient done, you got a surgery done under general anesthesia, and you used atracurium as your relaxant of choice. You intubated the patient with atracurium, you maintained the muscle relaxation with atracurium, and when it came time to reverse, you gave neostigmine to the patient. And then you extubated the patient. But as soon as you extubated the patient, the SpO2 started to fall. You put bag and mask at the patient's face, but you were unable to ventilate. Right? There was no chest rise. You auscultated the patient and the chest was completely silent. The patient started to turn blue. Cyanosis started happening. There was tachycardia. SpO2 started falling. BP started shooting up, or the the patient started going in shock. So essentially, hemodynamic instability started happening. These are all features of laryngospasm. So the patient entered laryngospasm. Now the treatment of laryngospasm is varied. You apply what your laryngeal pressure. You can give a small dose of propofol with lidocaine, and ultimately the ultimate treatment of choice for laryngospasm is you have to give muscle relaxation, because vocal cord laryngospasm is essentially a spasm of the vocal cords. Vocal cords are nothing but muscles, so you have to give a muscle relaxant, and the muscle relaxant of choice is scoline. Let us suppose the time between the administration of neostigmine and administration of scoline was 5 minutes. So within 5 minutes, all of these things happened, and you had to give scoline to the patient within 5 minutes. So what will happen? So normally we know that under normal circumstances, the duration of scoline is around 9 to 13 minutes. But now, after you have given neostigmine and after 5 minutes of giving neostigmine, you gave scoline, the duration of scoline is now prolonged to 35 to 45 minutes. So then you will have to keep on ventilating the patient for approximately 45 minutes till the patient starts to come out of the paralysis. And the reason is simple. Neostigmine not only inhibits acetylcholinesterase enzyme, but it also inhibits pseudocholinesterase enzyme, which is responsible for scoline's metabolism. So this was just the basic, a little bit in-depth discussion about succinylcholine. I hope it was beneficial for you. Succinylcholine, although is a drug that is not so frequently used nowadays, but it still is a pretty important drug. In the next lecture, we will be talking about non-depolarizing muscle relaxants, but subsequent to that, I will also talk about special patient populations, and I will also discuss succinylcholine in those sections. For example, I will talk about the use of succinylcholine in children, in elderly, in hepatic failure patients, in renal failure patients. So that will be a separate lecture wherein I will just talk about overall use of muscle relaxants, both depolarizing like Succa and non-depolarizers in special patient populations. So I hope this video was informative, and succinylcholine is a very important drug for vivas, for exams, and also for general day-to-day use in anesthesia as well. Thank you.